Okay, that should have worked. Can you see my slide there and hear me all right?
Yep, certainly can, Barbara. Yep, that's great.
Great. All right. Well, thank you so much for inviting me here today. And it's lovely to meet you. I'm really grateful to you to sponsor my fellowship. So it's quite nice to come and meet you all in person. I'm sorry I couldn't be there for my induction. There was a clash. So I'm going to talk to you today about a few things. I wasn't really sure who my audience would be and what you'd be interested in. So my plan is to cover a few different bases and hope that there's something of interest for everyone. I'm going to talk a little bit about my sort of accidental journey from clinical nurse to nurse researcher, because I certainly didn't plan to become an academic. I'm going to talk a little bit about behavioural science and what I call the why don't they questions that are often brought up by clinicians, and give you some examples of projects that I've led that are based on behavioural science but are clinically applied, so hopefully you'll see the relevance. And then just tell you a little bit about the opportunity that the scholarship offers in case I can tempt or encourage any of you to apply, because there's no need to encourage, it's all good. So I hope that sounds all right. I think we've got half an hour and I hope there'll be lots of time at the end so that we can have a discussion. It's a bit difficult in the Zoom thing to take questions as we go because I can't really see you all, but you can interrupt me, I think, or at the end ask any questions. So here's the story of my clinical career. And the reason I'm telling you this is just for maybe more junior nurses, is to show that you don't necessarily need to have a grand plan at the start. I certainly didn't. I bumbled from one thing to the next. But I think if you follow your interest and your curiosity, then it takes you to interesting places. So this is where my curiosity took me. This is me, would you believe? Fresh-faced and enthusiastic. I qualified as a staff nurse in 1991. And yes, we still wore hats and we got rid of them shortly after. And my first job was in acute medicine. It's the usual stuff, people with pneumonia, strokes and heart attacks. And, you know, I loved it because it was all about nursing care. The heart attacks really scared me. I was absolutely terrified that someone was going to have a cardiac arrest and that I wasn't going to notice. And so then I moved to where else but CCU. And there I learned to love a cardiac arrest. And actually I really loved that role because it let me do much more of hands-on care than I could do as a qualified nurse in a general ward. We were amongst the first nurses to start doing advanced practice tasks. So even as a newly qualified nurse, I was giving IV drugs, we were defibrillating, we were giving drugs in an emergency without prescription. And we were also had an evidence base for our practice, with cardiology being one of the first areas to embrace evidence-based practice. So that was all quite usual before it became the norm, really. And it was the best nursing care that to this day I've ever seen. We had such a strong team of people who were all totally committed. And I was there for 3.5 years. No one left in that time. It's just unimaginable nowadays, isn't it? In a staff of there was about 40 of us. So I couldn't get promoted. So I had to leave. But I would have trusted any member of that staff to care for my family. And it just, when I was writing this, it just made me reflect on sort of the consequences of the situation that we've got now with staffing. So I had to leave, and what I really wanted to do was be a cardiac rehab nurse. And I was doing my degree at the time part-time. I did the old training where we didn't have degrees, but I went and did it, paid for it myself and did it part-time. And I got interested in psychology and health promotion. And so then I made what my cardiac colleagues thought was a really weird move to an HIV prevention service, working in the community to prevent the spread of HIV. So I was in discos giving out condoms to young people. I was in gay nightclubs, doing HIV testing, working in a needle exchange. So it was so different, but I learned lots. And I, most importantly, got a much broader perspective on what health was about, and how that might translate differently in different populations. I also met a really nice IT bloke who is now my husband. So we enjoy at dinner parties telling people that we met in a drug problem centre and watching their faces. But all that experience of health promotion and experience in the community then let me land my dream job as a community cardiac rehab nurse. The British Heart Foundation created these roles across the country, pump priming them, so paying for the first 3 years, and in the hope that trusts would then make them permanent positions. So this was a great job. I would meet patients in hospital, and then after they were discharged, I would run around in my little red Corsa and visit them at home and just help them to give them advice about getting back to normal, do the secondary prevention, make sure they were on all the right tablets, and liaise with primary care to make sure that was right, and help them make some of the changes that they wanted to make in terms of their diet, exercise, that sort of stuff. So I was successful in creating, the trust created a permanent role, and sadly I couldn't take it because, you know, me and that IT bloke had started a family and decided to move back to Scotland. So I had a couple of years out to look after my daughter, and I took a job at NHS 24, which is the equivalent of NHS Direct in England, just because the hours fitted around childcare. I was a team leader, so helping establish the service and support the nurses who were giving advice over the phone. I didn't love it, I have to say. So when I found a piece of paper by accident on the photocopier that someone had printed out about a scheme where the Scottish Government were going to pay nurses and other allied health professionals to do their PhD, I thought, well, why not? So then I had to propose a topic. And so in this slide, I want to show how all those different experiences sort of led to the creation of that topic. So, you know, in coronary care, I'd learned that the people who took longer to get into hospital did worse. You know, they have worse outcomes. The treatments are most effective if they're given quickly. I'd learned that there are things that we can do to change people's behaviour so that they can have better health outcomes. And when I was working as the cardiac rehab nurse, every single patient I spoke to told me the story of their heart attack. So I heard all the stories about, oh, I thought it was indigestion, so I took a Rennie, and then, you know, we went out for whatever, and then I came back and it was still there. And so then I started to get worried. So I understood, you know, that people weren't in denial, as everyone assumes. They were making sort of common sense judgments about what they were experiencing. They were trying things, and it was only when those things didn't work that they started to worry it was something more serious. And then when I was working in the NHS 24, the telephone helpline, we had absolutely thousands of calls every day for chest pain. And, you know, those primary care physicians were sort of frustrated that people were bothering them about nothing. Whereas I understood that we tell them to bother you every time they get chest pain. So, you know, all these questions, all of that came together for me to develop this question. So does how people think about their symptoms relate to how long it takes them to call for help? So that was the project I proposed. And I hope it sort of shows that the solution to a problem in one part of the system can lie in another. And the experiences of another part of the system can help provide a different perspective that might help you understand and solve the problem that you've got in your area. And also thinking that we all move through different jobs and have different experiences. So just if we all try to think about what our unique contribution might be, I think is interesting. Anyway, I was lucky enough to get the opportunity to do my PhD, and this is it. And what I did was to use the recorded calls. All the calls to these services are recorded routinely. So I was able to analyse the calls of people presenting with chest pain and explore how they were describing their symptoms and see if the theory fitted. And then I contacted them within 10 days of that phone call. So calling a lot of people who might have been very unwell, or their families who might have lost them actually, but asking them to complete a survey about what they believed about their symptoms at the time and see if that predicted how long it took them to call. So this wasn't a brand new topic. Lots of people had looked at delay, but what I was able to do was different, was to have those recordings of actual calls. That wasn't something that had been done before. And also I used theory. I was being supervised by a health psychologist, so I used health psychology theory. And so that was different as well. And I was just wanting to say something about, I think nurses tend to hate that word theory, and I think there's a lot of negative reactions to it. But I think it's really important that we use it, because all it is a summary of what another discipline has learned. And we would be really daft to ignore it and start again. We just end up in loops, reinventing things and not moving on. So you don't accept the theory as perfect, but if those relationships have been confirmed, then that's a good place to start. And we can modify the theory if we learn that something isn't correct. So yeah, look for known, even if it's not known by our own discipline. And I don't think nurses are too good at that. Anyway, I spent 3 years doing that. And the answer was yes, but it's complicated. And for a lot of nurses, I think they think that's the end. You've got a PhD, that's amazing. And it is amazing, it's a huge achievement. But it's really just the beginning. The PhD is just a training in how to be a researcher. And you're learning these skills to then be able to apply them to big and important problems. I was really lucky. I had a super positive experience, an amazing supervisor. He was a really world-class researcher. So I was encouraged always to do the best that I could, to go to the highest standard, to think about an international audience. And I really got the bug. You know, I just loved it. I think it suits the sort of detail-orientated part of my personality that, you know, didn't always go down well in clinical. But also I really like to plan and think about things in advance, and research allows you to do that. And all the different stages feel really different. So for someone who gets easily bored, it really helps me. So, you know, the planning of a study feels very different from collecting data, which feels very different from writing and presenting about it. So yeah, I was sold and keen to go on to the next stage. So I understood a lot about why people delayed, but I hadn't done anything to make a difference. So my next question was, you know, can we change people's behaviour so that they don't delay? Can we tell them about how important it is in a way that will actually change what they do? So yeah, that's me. I've accidentally landed in research, and this is the sort of research I like to do. But I thought it might be nice just to say a little bit about behavioural science and why I think nurses should pay attention to it, think about it, and how it might help us with some of the problems we've got in clinical practice. So these sorts of questions, like why don't they check their sugars? Why won't they lose weight? Why won't they have the vaccination? Why won't the doctors wash their hands? And why do the nurses bother me for unnecessary things? These are the sorts of things we hear our colleagues say all the time. And there's lots of puzzling about why people don't do what we would like them to do. And generally the solution is that people need educated, and, you know, leaflets are made and people are sent on courses. But information is rarely enough to change our behaviour. And, you know, we're all health professionals, but I would gamble that most of us in this virtual room aren't perfect in relation to all our health behaviours. We have the information, we know what we should be doing. And the truth is, it's really hard. It's really hard to change our routine behaviours. But thankfully, our colleagues in behavioural science have been working on this for a long time, and they have a number of models to explain behaviour and to predict behaviour. And the trouble about it is that they use a lot of language that is difficult to access, and I think this makes it quite hard to engage with. And I spent, I think, the first 2 years of my PhD listening to health psychologists use these words and not having a Scooby what they were talking about. But they do have helpful things to tell us about what predicts behaviour. And this slide shows you the theory of planned behaviour, which is one of the most commonly used. It's in over 4,000 papers, and meta-analyses of hundreds of studies have confirmed that these relationships hold true across across a range of behaviours. So on the right is behaviour. Now, it's not all behaviour, it's a specific behaviour. So taking an example, the vaccination, going to get vaccinated against COVID, for example. In order for that behaviour to happen, you have to have an intention to do it. So that makes sense. You're not going to accidentally, without intending to, stumble across a COVID vaccination. You know, you're going to have decided you want to get one and go and get one. But equally, we've probably got intentions to, you know, do brisk exercise for 25 minutes 4 times a week, or not to eat chocolate, or all these different things. So the intention doesn't always equal behaviour, but without an intention, the behaviour is extremely unlikely to happen. So it's necessary, but not sufficient. So we work a lot on creating intentions towards behaviours. And the things that predict intentions are our attitudes towards the behaviour. So if in general we feel positive about vaccination, that makes us more likely to intend to do it. Our subjective norms, so what we think other people think. So if you think that all your colleagues and everyone thinks that getting vaccinated is a good idea, then you will have a high intention. But if you're in a sort of social media bubble where everyone thinks it's a terrible idea, then you know your intentions will be less positive. You'll be less inclined. And then there's perceived behavioural control. So how much control do you feel you have to do this behaviour? And so, you know, if you're, for example, a young child in the UK at the moment, no matter how positively you feel about having a COVID vaccination, it's not available to you. So you have to feel that you've got some control over this decision to intend to do the behaviour. The other thing that our colleagues in behavioural science have done that's really helpful is to develop a taxonomy of techniques that we can use to change behaviour. So there are 93 in this taxonomy, and there's definitions and examples. And so what I would say is that providing information is one of these techniques, but there are 92 others that are probably going to be more effective. So things like asking someone to sign a commitment, giving someone feedback on their behaviour. So for example, auditing, hand washing in a ward, that would be a type of feedback. Or social comparison. So giving feedback to staff on your ward that, you know, you washed your hands 12 times in a shift, but the average is 25, or a more positive version of that. So there are lots of different things that we know can change behaviour. And worth thinking about, I think, as we get overloaded with information. So that's your crash course in behavioural science. And I'm just going to talk about a couple of projects that I've led where we've used this approach in relation to clinical problems. So the first, no surprise, being back to patient delay with symptoms of heart disease. This was my first grant. I got it. The Scottish Government funded us to develop an intervention to try and reduce delay. The people in yellow are cardiac nurses and a consultant cardiologist, but the others are a statistician, a digital artist, a trial methodologist, and health psychologist. So big problems like patient delay with symptoms aren't going to be solved by a single profession. It would be really arrogant to think that. So don't feel like you have to know everything. You just have to bring in the expertise that you need to help you solve the problem. So we worked with all of those people and with patients with heart disease and their relatives to make an animation that's designed to, it's got the behaviour change techniques built into it. So I'm going to show you a little clip and you might see stuff about the consequences of delay and demonstrating the behaviour that we would like patients to perform, which includes taking their GTN spray and timing 15 minutes. And then I'll show you a couple of the things that we did afterwards that were more active things that required people to think about, to plan ahead for things that might get in the way. So it's really simplistic to say, if you have chest pain that lasts for more than 15 minutes, phone for an ambulance. But you know, what if you're in the middle of a meeting or giving a presentation or looking after grandchildren? And so people were asked to imagine things that might be a problem for them. So hopefully this will work. Sometimes we have trouble with the sound, so let me just start it and then. Yes, we're starting in the middle. It doesn't start like this for real, but just to give you a little clip. Oh, it's not playing.
My students, let's say their body size has changed, and they said they're uniform. What's the plan?
Well, what's his name? My little lovely man, I love
Musa.
Musa.
I think it's breaking up quite a bit, Barbara. People aren't able to hear it. Yeah.
Okay, no problem. That's a shame. But hopefully you see from the visuals, it gives you a flavour of what it was doing. And these are the sorts of exercises that people did afterwards. So this one's sort of thinking about the consequences of delay. So what would happen if I call for the ambulance, and what would happen if I didn't? And that encourages people to think through the consequences. And then this is creating an action plan. So people actually writing down, in this circumstance, I will do something. And there's evidence that doing that makes you more likely to do it in the event. So we trialed this in an online trial, asking people to respond to a range of symptom scenarios. So some of them were chest pain with or without nausea, but there was also sore toes and pain passing urine and that sort of thing. And those who received the animation were more likely to seek help promptly, report that they'd seek help promptly. So that was good. But of course, it doesn't tell us, what would happen in the real world. So we've got some more funding now to go back to those people 5 years on and see if it had any impact for real. So yeah, the next lesson, research takes patience, takes a long time to do these things. So the second example of where we've applied behavioural science is to CPR. So there's over 30,000 people a year have an out-of-hospital cardiac arrest in the UK, and prompt effective CPR is the biggest thing that can reduce that mortality, but it's often not provided. So we need to get more people, even when they're trained. So we need to get more people feeling confident to do CPR. And I'm hoping from what I've told you so far that you might be thinking that behavioural science can help us here. So you'll all have been trained in CPR, and the models of training focus a lot on knowledge, on skills, and getting your technique correct. But I think they don't focus enough on confidence and people's concerns about getting it wrong, and that this means that they hesitate in real life. So we did a systematic review to look at the sort of psychological and behavioural factors that are associated with whether or not people initiate CPR. And indeed, we find that people's perceptions of their capability, their concerns about doing harm, and just feeling overwhelmed by the emotion of the situation prevented them or made them less likely to initiate CPR. This part of the review is still underway, but we looked at what's in those interventions where they're trying to train people to do CPR and make them more confident. And you'll see that there's 5 techniques that are used a lot. So there's a lot of instruction, there's a lot of behavioural practice, and feedback on performance, but they don't use any of the other techniques. So there's definitely opportunities to do more in terms of that. So we got another grant to develop a text messaging intervention and where we try and use behavioural science and send those behaviour change techniques to people in the months after their training to try and hold on to that confidence that they come out of training with, but which wanes over time. And the idea is that we hope that these messages will increase their confidence and their intentions to do CPR. And the reason we went with text messaging is that it gives us that ongoing interaction beyond the initial training. It's engaging and acceptable to people, and it's been shown to reach people that are maybe tend to be hard to reach. And we can send the behaviour change techniques with perfect fidelity, so we don't have to train people to give the techniques in a certain way, and we can incorporate videos and pictures that help understanding. So here's just a couple of examples of the messages on the left, how they would appear to the participant, and that's the behaviour change technique that we're using. So in this one, we're trying to reduce negative emotions and help people to anticipate those negative emotions and think of things that will help them to act irrespective of the negative emotion, and a little bit of problem solving there. Here's another one. So here we're using anticipated regret, which is where you encourage someone to think about how they might feel if they don't do CPR. You know, we had to be really careful about how we worded that, because what we don't want to do is induce guilt. But we worked closely with lay people, and they told us off whenever we got it wrong. So they wanted the tone of them to be very positive, and I hope that's what we've achieved. So these get sent over about 6 months. We did a pilot trial where we recruited 20 people who'd been trained in CPR. We measured their confidence and willingness to do CPR in response to a range of scenarios. Then we sent them these messages in a condensed form over 6 weeks, because we just didn't have time to wait 6 months. And then we measured confidence and willingness again, and we interviewed them. And this is our main outcome. So how likely people were to do CPR for the CPR scenarios. And the dots on the left were their scores beforehand, and the dots on the right are their scores afterwards. So people were already very highly motivated and intending to do CPR, but hopefully you can see the trend is that we maintained high intentions, or their intentions increased. And the biggest increases were in the people with the lowest intentions at the start. So that's looking really promising. This is self-efficacy or confidence in their abilities. And as you can see on the left, there was a wider range of scores of confidence, but most people improved after the intervention, and some quite significantly. And you don't need to look too closely at this, but these are the behavioural predictors. So this is telling us that people had more positive attitudes and felt more perceived control over this behaviour. They felt like they could do it. So this tells us that the intervention is working in the way that we planned. And surprisingly, we were a bit concerned that these are not nice messages to get. Imagine getting a message every day about CPR. We weren't sure how it would go down, but actually it was very acceptable, and 85% of our participants accepted all the messages. A couple stopped just before the end of the trial, but not for anything to do with the messages, just personal circumstances. And they can be delivered automatically. So this is something that can reach a lot of people quite cheaply. Our participants were generally positive about it. So I'm currently writing a bid for a big evaluation from NIHR. The other thing I'm doing is the project that the British Heart Foundation are funding me for at the moment for my fellowship, where I'm taking a similar approach to see if behavioural science would help the call handlers who are coaching people through CPR on the phone and get them there faster. So, but I also just wanted to draw attention to these fellowships. There's PhDs and postdocs that the BHF will fund. They're amazing opportunities. So if there's any cardiac nurses, I would encourage you to have a look at those. And then finally, just to finish up about the Florence Nightingale Foundation, this is another example of me just bumbling around. I applied for the fellowship because I wanted to go on a course that was part of it. A friend had recommended it, and I was accepted, and the course was great, but I've had so much more besides that I just feel so incredibly lucky. So I've been adopted by Sigma and met all you lovely people, which has been lovely, and particularly Liz, who's been so welcoming. I got mentorship from Professor Aisha Holloway at Edinburgh, who we've had lovely, challenging conversations about where I'm going and what I want. I've been to the RADA Leadership Communication Workshop, which was just amazing and really helped me to overcome some of the things that I find challenging as a leader. And whilst doing that, developed these close relationships with my cohort of other nurse leaders from across the UK. So for me, it's been massively positive, and I would really encourage anyone who is interested to have a look. The website's on that slide there, and if anyone wants any help with an application, I'm happy to help. And as part of that, I'll be undertaking a project, and I'm trying to explore what helps or hinders nurses to lead research, just recognising that very few of us are doing it. So I'm systematically identifying all the nurses who've been lead investigator on a funded research study from the major funders, NIHR, MRC, CSO, people like that, and just asking them these 5 questions. I think this came from my sense that the decisions that are being made about how we increase capacity and capability, we're repeating a lot of the mistakes that have been tried before, and a lot of the people who are making these plans and decisions haven't ever led a funded research project. So I really wanted to get the voices of the bright spots, the people who have been able to make it happen when things were not particularly supportive of them. And so there's really interesting things coming out of that already. So that's great. So just to summarize, for me, I just want to say, for me, it's still all about this. It's all about improving patient care. There's no ivory tower for me. And I think actually that's true for most nurse researchers. You know, if you just look at the process where only 1 in 5 applications is successful at most major funders, everything's scrutinized by clinicians, methodologists, members of the public. There's just no way you're getting funded for something that is unimportant. So this idea that we're all in little offices thinking about stuff that doesn't matter, I think is quite far from the truth. And I think we do each other a disservice by talking about it like that. So yeah, it's still all about improving outcomes for patients. I hope that you might think sometimes about how behavioural science might help when you're puzzling over these why do they questions, and just think what might be behind the behaviour and challenge your own assumptions about that. And then finally, I would just ask those of you who are not in research or involved anyway, to be a cheerleader for your nurse colleagues who are trying, or even better, to get involved. If we don't do research about what we think is important for patients, then we'll be forever stuck with what other people think is important. And that may be drug trials. You know, that's the reality of it. So yeah, think about what your contribution might be, and seek out people who can help you make it happen. I think that's all I wanted to say. Thank you very much.
That's brilliant, Barbara. Thank you very much. Do you want to maybe unshare your screen, but maybe in the chat put your contact details as well, if that's okay, and we can go on to some questions. So that was absolutely brilliant. So one of the first questions we've got is from Lee, and he wondered, what was your decision making to choose to adopt the common sense model of self-regulation, because it seems really fascinating.
It was suggested to me, and then when I read it, it really fitted well with what I'd observed. So for those of you who don't know, the model suggests that people make sense of their illness based around 5 components. So what they think the cause is, how serious they think it is, what the consequences are, what the treatment options might be, those sorts of things. And so then when I looked at analysed the calls, the model matched almost perfectly. There was nothing that someone said on a call that the model didn't explain. Then in terms of just explaining how long it took them, you know, it was less clear with that. But I did find it a really helpful model, and I still think in those terms if I'm thinking about how someone's making sense of their symptoms. And myself, you know, if I'm panicking about what I should do about a symptom, I think, oh, it's that, what's the consequence? What am I worried about? So I guess I was shown there was a range of options, and that one just seemed to fit.
Yeah, brilliant. And sometimes it's just serendipity, isn't it? The right model arrives at the right time and you think, oh, this is perfect. So yeah. Then there was another question from Alice. Do you think that behavioral science for patients can be transferred to nursing management?
Yes, they might not like it though. But yeah, and actually my colleagues, the health psychologists I've worked with, they've done lots about professional behaviour as well. So, you know, whether or not dentists do sealants on children's teeth, whether or not doctors prescribe antibiotics for upper respiratory tract, they've used behavioural science to intervene to change those behaviours in the way that we want. So yeah, certainly. But I think I suspect from that question you're thinking, can we secretly intervene on them? That might be more difficult, but you know, certainly you could look at the techniques, and giving feedback on behavior, for example, is a technique, and yeah, it might change behavior, but also you know, find some evidence and persuade them with evidence.
Yeah, no, exactly. Now I can see that Emma has her hand up. Emma, you want to unmute? And
hi, thank you so much. I really enjoyed your whole presentation and feel very inspired by everything you've been sharing.
Oh, thank you.
I wondered if there is a cohort or a network of nurses who are skilled in behavioural science, and whether it's possible to access that wisdom for different topics. I work a lot in sustainability at the moment, and there's a lot of behavioural science used in sort of general sustainability work, but I'd be really interested for some nurse specific knowledge and skills. So I just wondered if there was that kind of network.
Yeah, thank you. I don't think there is. I don't think there's many of us. So I had a little idea when I was in the UK Society for Behavioural Medicine on the organising committee for a bit, and I had an idea that I was going to get all nurses enthused about it. But then I looked around and there weren't many. But that doesn't mean it couldn't happen. And the UK SBM conference is a really good one to go to meet other clinicians particularly. So the health psychologists, they all talk to each other about health psychology. But the UK Society for Behavioural Medicine is a conference where lots of clinicians go, and it's all really applied. And I always find it really inspiring because it's good science, you know, they're doing really good stuff, but you can see the relevance. They're not just sitting with hundreds of students working out if this predicts that, with, you know, it's applied. So that would be a place to go. Or if you were looking for just people related to your area, by all means get in touch with me and I can ask my colleagues and try and hook you up. The stuff about sustainability, I know there's Joe Hart and another colleague in Birmingham, they're health psychologists, but I know they're really interested in the environmental and behaviour change stuff. That's
great. I can't see any more hands up. I had a question actually. There's always a description about the worried well going to their GPs, you know, when possibly needlessly or whatever. And I was wondering how we balance that between the kind of uncertain ill. So you know, we obviously don't want to stop some with a worried well carrying on going to using emergency services or the GP because there might be something wrong with them. But clearly we don't want, I presume, particularly heart related, you don't want every single person that ends up with any type of a chest pain that ends up being indigestion or whatever to be contacting emergency services. So I was just wondering from your research, what kind of balance you've managed to advise or develop?
Yeah, that's a really good question. And actually I skipped over it because I worried I was going to be talking for too long. But in our trial, what we showed was that we increased people's intentions to call for help with their cardiac symptoms, but there was no difference on their intentions to seek help with the sore toes and the urinary symptoms and the non-serious stuff. So that was really reassuring, and that would be an important, because what we don't want to do is panic everyone into overusing services. But I do think that we also, when we make these judgments that people have called unnecessarily, we usually make that judgment once we've done an ECG, a blood test, and a full physical examination. It's actually very hard to make the judgment on the basis of symptoms only. And that's what we ask patients to do. So I think providing much, and it's a shame you didn't see the animation, but providing much more specific information about the trigger points for phoning the ambulance. So what type of pain, for how long, and then what do I do, you know, so, and trying some self-care stuff with the GTN spray, the sitting down, you know, and it's only if it lasts for more than 15 minutes. So I think if you think about, oh, we tell people, oh, call us if you're worried. Well, you know, we're all worried about everything all the time. Yeah. But giving them specific criteria. And then I think that also takes the responsibility away from them. And I would like to think that anyone in an A&E department who has someone presenting with symptoms of 15 minutes who's got a cardiac history, there would be just, there's no blame, you know, you did the right thing, even if on this occasion. But I think we could also use behavioural science to address the opposite, where we have got people who, for complex reasons, are phoning at the drop of a hat. I think we need to get behind what that's about. It's about something.
Yes, it was interesting, wasn't it, during COVID, that the death rates from stroke and heart attacks went down in hospitals, but they didn't go down nationally. It's just that people weren't, you know, they were afraid about going to an A&E or just didn't go to their GPs or whatever. So it's important to make sure that people are still very aware, isn't it? And regardless of almost what's going on, to still make contact. Yeah.
Yeah, and I do feel the fear whenever I see these, we're terribly busy, it's a bank holiday weekend, don't bother us type messages. Yeah. I understand the intent, but I do think that there is a danger that it puts off people who really need to be making that call. Of course, if the ambulance is going to take an hour and a half to get to you, it's all irrelevant, which is the situation we've been in recently. But hopefully things are getting back to normal, where these minutes make all the difference. And of course, they're at higher risk of cardiac arrest. So, you know, if you're delaying, the chances of you having that cardiac arrest somewhere where there is no one with a defibrillator, that has a big impact on mortality too. Yes, yeah.
I mean, undoubtedly, putting AEDs in supermarkets and railway stations and, you know, exercise areas has saved countless lives, hasn't it? You know, that's been quite transformational. Yeah.
But someone has to have the confidence to apply it and do CPR while they're waiting on it.
Yes. Yeah. No, exactly. Any other questions for Barbara at all?
I think I saw one in the chat about the RFPB call.
Oh, yes. Thank you. Yeah.
I don't know who that was. Do you want to? I just saw the RFPB and I was like, oh, yeah.
I only mentioned it. It's Camille Cronin. I'm new today. Well, I'm director of research at the university. So when you had that slide up, I went, oh, okay. And obviously, it's very significant what you were saying. And as nurse leaders, but if you read the call in that section, it talks about obviously the lack of nurses doing this type of research and all the issues. And I think it was a call particularly related to what you were saying. So I just kind of mentioned that, and it's specifically around research for patient benefit. And kind of just when your slide flashed up, that's kind of what struck me.
Yeah, no, it's brilliant. And they've put out that call specifically because they know that nurses, despite being the biggest section of the workforce, are the least likely to apply and the least likely to succeed in getting an NIHR grant. As a Scottish nurse, I'm not eligible to apply for that, but I can support an early career researcher. So if anyone wanted help to write an application, I'd be happy to help. I'm helping one cardiac nurse. Yeah, because it's hard to write a competitive application and it takes time. And, you know, those of us that have had to do it a few times, we've learned some tricks that can make the most of someone's idea and give them a better chance of success. So I think that's a call that nurses, you know, I'm saying 1 in 5, if you go to a general call, I think your chances of success on that call are as good as they're going to get for anything. So it's definitely worth giving it a go if you've been thinking of an idea.
Yeah. Well, one of the things we might recommend for you, Barbara, is we've just kind of redesigned our chapter research committee, and it's going to be very much around supporting people to develop research skills and maybe putting on a series of masterclasses to help people to do that. So if it's okay with you, I'll put you in contact with Parveen, who's the chair of that committee, because the expertise that you've got would lend itself really nicely to maybe contributing to one of those masterclasses or something like that. Yeah,
that would be great. I would be delighted to do that.
Great. Okay, any other questions at all? Yes, Adrienne, you just need to unmute yourself. That's it. Away you go.
Good. Just an observation that not to sort of diminish the importance of providing information to people. I was just speaking with a gentleman last week who was pronounced cured from his prostate cancer by a surgeon this month. And he said, you know, nobody ever tells men to get a PSA test. He said, the only reason I found out about this is that I turned myself in for it. And he said, whereas women always get told to have a mammogram, etc. I just thought that was an interesting observation, and that gender specific kinds of behaviors might be important to look at as well as the ordinary thoughts about this topic. But anyway, just a recent observation, which I thought was really important, since it's such a sort of pervasive cancer that men are dealing with right now. I just wanted to add that.
Yeah, and it's an important point. We in behavioural science tend to always be down on information, but information is also important. And, you know, so information will change some people's behaviour, but if the information hasn't, more information is unlikely to. And so that's when you need to try and try other things. And it's not the only answer, is the point I perhaps should have made more clearly.
The other quick points on a totally different area about the observation I made about other things like cultural beliefs. I recollect one family that lived across the street from a clinic and didn't want to get any immunizations or care because they said if it's going to happen, it's going to happen. They're very fatalistic about their lives. So there are so many other things that can play into behaviors. Just another observation.
Absolutely. And the model that someone mentioned, the common sense model, you know, that people have ideas about cause and consequences like those, but yeah, that those are situated in a wider, you know, cultural and societal situation. And so, you know, how we would think about what you should do in terms of a heart attack and CPR, for example, would be very different in a low resource country where there is no emergency care, there is no ambulance. CPR is pointless, you know, so yeah, it's all situated, but I think they are helpful models in helping us understand and have a go at changing things for most people.
Yeah,
Thank you.
Great. Well, thank you very much indeed again, Barbara. That was really interesting and lovely to see how your career has built to be able to make the most of all of the expertise that you're developing as you go along. So it'll be great in a few years' time to carry on seeing that that trajectory and see where it takes you as well. And we're delighted to have you in Sigma and in our Phi Mu chapter as well. So it's great to have you here. Lovely. So we're now going to move on to our induction. And I think a lot of our new members to be inducted, I can see on the screen, which is great. So if those who are going to be inducted would like to show themselves on the screen so that we can see you all in person, that would be wonderful. And I'm just going to share my screen so that I can undertake the presentation. Need to work out which one it is. No, it's not that one. Introduction. All right, just let me fiddle around for a second. Oh, right. Okay, let me have another look. I did share it all earlier on. Oh, here we are. Here it was somewhere. Great. So let me just start from the beginning. Just ignore me while I just flick back. Right, so welcome everybody to your induction ceremony this afternoon. My name is Dr. Liz Westcott, and I'm delighted to meet all of our new members in person. I've met a lot of you on the email, so it's fantastic to actually see you as well. And thank you for coming along and celebrating this special occasion with us. So welcome to everybody. We've got a number of members from the board with us today, including our president-elect, Dr. Les Gelling, who's going to be taking over as president in June, July this year. So just to confirm for you all that our vision and mission of Sigma are very much aligned with everything that you have all put in your applications. So we want to be connected, empowered nurse leaders transforming global healthcare and developing nurse leaders anywhere to improve healthcare everywhere. And for more than 100 years, Sigma has been recognizing and celebrating excellence in scholarship, leadership, and service within nursing and midwifery. And the Honor Society, known as Sigma, was founded as Sigma Theta Tau in 1922 by 6 nursing students in Indiana University. And from those 6 founding members, our organization has grown to well over 135,000 active members in more than 560 branches in over 100 countries around the world. And those countries are growing virtually every week. So we also collaborate with several global organizations to improve the health of the world's people, including representation at the United Nations. And one of our own Phi Mu members, Charlotte McCardle, has become one of the 6 Sigma United Nations liaison members. So we're really delighted that Phi Mu has been able to support somebody to have such a pivotal role in both Sigma and the United Nations. So Sigma members are leaders at all levels of the healthcare industry, from students all the way up to chief executives. And the society extends membership to students in a baccalaureate or graduate level program who've demonstrated superior academic achievement or leadership. And to nurse leader candidates exhibiting exceptional achievements in nursing. So you're among a distinguished group of nurses, students, and professionals who have met or exceeded the rigorous standards required to receive an invitation to join Sigma, and you truly deserve our congratulations. So the leadership and scholarship that you've displayed represents the essence of the society, and we really are a big Sigma family together. So our founders chose the Greek letters sigma, theta, and tau, taken from the Greek words meaning love, courage, and honor, as they believe them to be the enduring values that are at the root of the nursing profession. And our crest, which adorns your membership certificates, which are being sent through the post at the moment, symbolize these enduring values, reminding us of our commitment to wisdom and discernment that are represented by the I, service, professional endeavor, and strength of leadership, as represented by the pillars of stone on the right and the left, and knowledge as represented by the lamp. And our key, embedded in our membership pin, reminds us of our charge to uphold love, courage, and honor, and is a symbol of scholarship. So the cup denotes satisfaction of professional life. The circle with its 6 stars represents the 6 founders, and the lamp is the lamp of knowledge. And the letters in black represent our charge. And remember that our key symbolizes your commitment to nursing excellence. So the purpose of this ceremony is not only to honor you as new members and celebrate your successes, but it also serves as our pledge to you to support you throughout your nursing career and to be a lifelong resource for you. This support will come in part through the opportunity to participate in Sigma's communities of interest, mentoring programs, and academies. And you will also have access to benefits such as nursing continuing professional development courses, the Journal of Nursing Scholarship, worldviews on evidence-based nursing, and nursing centered. So your induction is not the end of the culmination of your scholarly or professional achievements. Indeed, your induction signifies the beginning of your membership journey and the start of your involvement within a global network of peers and mentors who are here to guide and support you wherever your nursing career may take. So at this time, we will receive into membership these outstanding new members. And I'll read out the names, and then if everybody would like to unmute at the end, and we will just give everybody a round of applause. So not everybody is present, but I'll read out all the names. So we've got Mahara Al-Maharbi, Helena de Resende, Nicola Wilkinson, Suzanne Turner, Adrian Jogoldo, Katie Hards, Jane Ball, John Unsworth, Alice Green, Camille Cronin, and Anne Gallagher. So if you would like to all unmute and give all of our new members a round of support. That's great. Now, we've got a number of our new members here, and I'm just going to stop sharing for a moment and ask if any of our new members would just like to say hello and say who they are and where they're based. So if any of you would like to do that, please do just chip in and say hello.
Yeah, I can. Can I?
Lovely. Thank you, Helena.
Thank you. Thanks. Thank you for this moment. I think it's great. Yeah. So pleased to be accepted. So my name is Helena. I am senior lecturer at Kingston University. My role now is teaching research methods and supporting research supervisions for master degrees. So I am an adult nurse by background, and my specialty is ICU.
Brilliant. That's lovely. Thank you, Helena. Katie, lovely.
I'm Katie Hards. I'm lead diabetes nurse in Oxford in the acute service, although I've got a strong primary care background, and also trained in Scotland, sunny old Aberdeen, a long time ago. And it's a real privilege to be part of this. I've just started my professional doctorate of nursing and has come to you through that experience and exposure to other excellent nurses. Thank you.
That's brilliant. Lots of good luck with the doctorate, Katie.
Thank you.
Thank you. Anybody else? Anne, lovely to see you.
Thank you very much. Thank you all, and good afternoon. Yeah, a great honour to be accepted into this community. Thank you very much. I'm Anne Gallagher, Head of Nursing at Exeter. I'm also Editor-in-Chief of Nursing Ethics, and I've, what should I say? I started my career in Belfast a very long time ago. I did adult nursing. Then I came to England to do mental health, so I'm dual-regged. And I guess I've been involved in nursing now for a very long time and continue to be very proud. And in fact, just today, I'm actually in Geneva today, and I've just had a meeting with Howard Caton at the ICN. So I feel this is like a double privilege day. So so it's so great to be amongst you, and thank you very much for this honor. Thank you.
That's wonderful. Thank you. Welcome, Anne. Suzanne, I saw you waving. Yeah.
Hi everybody. My name's Suzanne Turner. I'm a specialist practice nurse currently. I work with the Ministry of Defence for Defence Primary Healthcare, currently based up in the north of Scotland. Just about to take on a new post as a regional nurse advisor for the whole of Scotland and Northern Ireland. So changes ahead, but I'm exceptionally excited to be part of this organisation. So thank you very much.
Brilliant, brilliant.
Should I go next, Liz?
Yes, lovely, Camille.
Hi, I'm Camille Cronin. I'm a Professor of Nursing at the University of Essex, and very much involved in teaching across all nursing programmes, supervision of future researchers and doctoral programmes. So I'm quite lucky. My other role in the school is Director of Research. It's very, very busy in terms of across our nursing and allied health. I like to try and make research accessible. One of my key areas and focus is really kind of developing that relationship with our industry and clinical partners. So just trying to make that all look quite accessible. Really honoured to be part of this network with nurses and nurse leaders, and hoping to, be part of promoting nursing again in leadership, in education, practice and research. So thank you again.
Brilliant, that's lovely. Now I've got a message from Alice. Her signal is very poor, but she said that she's head of service at Sue Ryder Hospice, and she's a nursing doctorate student at Oxford Brookes University as well. So welcome, Alice. Adrian, lovely to have you here.
Hi, I'm Adrian Chuck Doyle. I'm the Director of Programmes at Middlesex University. I'm in the role of a mental health nurse here, but I'm actually dual qualified and probably more an adult nurse than a mental health nurse, which I think the students find fascinating when we're trying to do coexisting conditions and long-term conditions. My background was it's like what Barbara was saying about behavioural medicine. In mental health, it was purely in addictions. So individuals with those chronic illnesses, but in acute, it was in A&E and acute medicine. So I feel privileged being in this group, being amongst people who are passionate about leadership and improving both academia and healthcare for patients.
Brilliant, that's absolutely fantastic. And it's interesting, isn't it, that while we still have the 4 branches of nursing, so much between particularly learning disability, mental health and adult really it should be completely overlapping, shouldn't it? Just because somebody's got a learning disability doesn't mean they've probably may well have a heart condition and something else. And we sometimes we work with other professionals that stovepipe people, don't we? Whereas one of the joys about nursing, hopefully, is that we see the person and all of their needs, and we don't just see them as a condition or whatever. That's what we strive for our students anyway, isn't it? Nicola, would you like to say a couple of words?
Yeah, so I'm Nikki Wilkinson. Sorry that I'm wearing a mask. I'm actually in an office and we've had an outbreak of COVID again. So the way that the world is at the moment. So my role is a research education lead at Doncaster Royal Infirmary. My background is an adult nurse and my background is oncology and critical care. And I'm kind of looking at how we then bring down the barriers of undertaking research, both from a clinical point of view and an academic point of view, and looking at how we can then bring in learners from the university and actually have research placements and actually getting them running in the ground so that when they become qualified, it becomes standard of care and they don't see it as a an extra workload onto their already busy schedule. So I'm grateful for this opportunity, and it's really nice to meet everybody.
Brilliant, that's great. That's fantastic. I don't think I've left anybody out, hopefully. So I'm just going to share my screen again, and then we can carry on. Oh, no, wrong one. Sorry. Oh, it was there. Where's it gone? Sorry. Right, let's try again. Right, okay, let me. Okay, great, that's super. What I need all of you to do is to unmute who are our new inductees, and I will read out each line, and if you can then read that after me, that will be great. So first of all, I'll read out, I accept membership in Sigma Theta Tau International.
I accept membership in Sigma Theta Tau International.
And I pledge to fulfill its commitment.
And I
pledge to fulfill its commitment
to nursing excellence, knowledge, service and leadership.
To
nursing excellence, knowledge, service and leadership.
Throughout my career.
Throughout my career.
Brilliant, that's great. Thank you very much. So welcome to Sigma, everybody, and it's fantastic to have all of you here. So we've just introduced ourselves, and
service.
Oh, right. So there are loads and loads of opportunities for you to experience when you are Sigma members. And this is really, as we've said before, the start and the culmination of your career up until now. And we hope that we can support and give you great opportunities to carry on your career as well. So each biennium, Sigma installs a new president at the international level. And at the 46th biennial convention, we proudly installed Dr. Ken Dion and introduced him as the 34th Sigma president. And each president has a call to action to help guide members and chapters as we strive to fulfill our mission. And going forward, this will be an organizational call with influence from the board of directors. So this time, the organization call to action has called us to be bold. And as a profession, we have a habit of talking among ourselves, and we attend nursing conferences and we publish nursing journals and often remain in the silos within organizations where we're employed. And this status cannot remain if nursing is to take its proper role within the international remit. And we need to consider COVID-19 a wake-up call. The future is coming, and it will profoundly affect nursing education, research, healthcare systems, and models of care. Our profession must step outside its insular circle, and we must actively collaborate with disciplines outside nursing and healthcare to influence decisions about our profession, populations, and the planet in 3 critical domains. Those are economics, technology, and conservation. So economics, the science of decision-making, is all about power. The fluency in the language of economics and the power can better influence decision makers to recognize and utilize the value of the nursing profession. With technology, we interact with technology daily in our personal and professional lives. Therefore, we must be able to converse in a strategic manner with the stakeholders developing the technologies as well as those involved in purchasing and implementing them within our organizations. And to do so, we must be fluent in the language of technology. And conservation is not just about the planet, although it is a great part of it. It's an economic way of thinking. And many economies around the globe are based on consumption. And if their populations are not consuming more, their economies will not grow. And if their economies don't grow, they will suffer economic collapse. But these models in the long run are not sustainable. If we raise the collective voice of nursing to influence and inspire the populations who trust us, our leaders will be challenged to embrace a future different to the one we are headed towards. And nurses can lead in all three areas of education, research, and models of care. And I would encourage you all to learn more and participate in fulfilling the organization's call to action by visiting the Sigma website, sigmanursing.org. So as we conclude our ceremony, I want to take a moment to recognize and thank all of you for attending today, and to our chapter board and all of our chapter members for welcoming you and giving you, hopefully, what will be a great experience within Sigma. I'm just going to stop sharing now. So we've got a number of events coming up that you will all be invited to. Hopefully you're all receiving the numerous emails that we send out as a chapter already and are on the email list. One of the first things for you to do is to go onto the Sigma website and to populate your profile. So if you log on in your name and then go to your membership details, please do populate your profile if you can with a photograph and also with details about where you work and your research interests. And this will enable people to be able to find you within the chapter, to be able to link to you to get more information and also to put you in contact with people internationally for any collaborative work or discussions or whatever. And our next event is on the 4th of April, and that'll be at 6 o'clock in the evening. And that'll be a similar event to this, but without the induction. So we'll have either one or two speakers talking about areas of either research or project work that they're doing, and an opportunity to ask questions and to think how you might be able to link with them. And then a great date for your diary as well is our annual conference this year is on the 16th of June, Friday the 16th of June. That'll be in person at Sheffield University, but also will be available virtually. And we'll be sending out the flyer with the Eventbrite link for that in the next week or so. And there'll be numerous more emails just to remind you to join for that. But if you can't be there in person, but you can maybe just attend a couple of hours of it virtually, then please do register because we'd love you to be part of it and to see what we're talking about. The title for the event is 7 Years to Save the Planet. What can nurses do to help that? And it's around sustainability. And Professor Marion Lynch will be talking, as well as Dr. Charlotte McCardle from Department of Health, who is our United Nations link. And we've got a number of other speakers that we're lining up as well. So one of the sessions that we're going to be talking about is also how we think about sustainability with regard to homelessness and vulnerable people. So it's not just sustainability as in, you know, making sure that we dispose of cardboard in the right recycling bin, but it's around all the sustainability to do with healthcare and what nurses can do about that. So that'll be a really brilliant day. And it's being hosted, our venue will be at Sheffield University, which is great. And then the final date for all of your diaries is the 25th to the 28th of June in 2024. And our chapter has the great privilege of hosting the biennial Europe conference. And we will be hosting that at Bournemouth University. It will run for the Wednesday, Thursday, Friday of that week. And the Tuesday will be a kind of social calendar for people to opt into if they want. But all the presentations will be Wednesday, Thursday, and Friday morning. And it'll be a fantastic occasion for you to meet other chapter members, but also we usually to European conferences get a lot of international visitors, particularly from America as well. But because it's the European conference, there should be a lot of colleagues flying in from Europe for it as well. So that'll be in person, but it'll also be hopefully running at the same time in virtually as well, certainly for all of the keynotes, and we hope a lot of the presentations as well. Now, the abstract window for that will be opening on the 1st of June this year. And we've got a big marketing plan that's going to kick into place in a couple of weeks' time. But you can obviously attend without presenting, but this is a fantastic opportunity for all of you who are undertaking research or have undertaken transformational projects in practice or whatever, to use this as an opportunity to present at a prestigious Sigma conference. And it'll be reasonably priced, so that's a great opportunity. Now, all of you hopefully will be starting to link up with your hub leads, and also will be allocated a buddy to look after you for the next 6 months. Please do make a lot of use of that. When you first join Sigma, it's there's so much out there. It's useful to have somebody to guide you through the websites and guide you to where you can get the best information and things like that. The other thing that we do is that we run monthly drop-in sessions for any member of the chapter to just drop in. The sessions are run for an hour, but you can drop in for a few minutes or the full hour if you want to. And that's an opportunity if you have any questions at all about Sigma, or if you have any questions about nursing and you want to find somebody in the rest of Sigma that's involved in that work, then we can put you in contact and that sort of thing. So the drop-in sessions are advertised every month, and please do feel free to make most of those. And Les and myself, obviously I'm current president and Les is president-elect. We're always here at the end of an email. So if you have any queries whatsoever, if there's something that you can't link into, or you're not sure how to get the best out of something, then just email us and we'll help you. Because as you all know, Sigma is like any organization, you get out of it what you put in. And what we hope to be able to do is to support you to get loads out of Sigma and really enjoy your journey with us. So I think we've come to the end of our session now. And it's wonderful to see so many new members. We've had 11 new members just in the last few months. And we've got more members that will be lined up for our next induction event, which will be June as well. If any of you have colleagues that you're working with who you would like to recommend to join Sigma, just send me their email address and their name, and I will send them a personal invitation, copying you in as well and putting you in on the letter. And this is the way that we grow. So the idea is that our current members are the people who are our best ambassadors to go out there and recruit new members as well. So please do feel free to spread the word, and I'm more than happy to have any one-to-one chat with all of you who are new, but also with anybody that you'd like to recommend to join. It's a great opportunity, and particularly if you're running departments or if you're running programs, it's a great opportunity for PhD students and master students to think about joining as well. This can really so much help their career, and it helps people think far more globally. You know, you're immediately exposed to nurses in all parts of the world, which can only really enhance nursing care. So thank you so much. Thank you again, Barbara, very much for a really inspiring talk earlier. That was really interesting, and we'll be very interested to see the results of your latest research as well. That would be great. Hopefully we'll hear you in Bournemouth in June next year. So that's great. So I want to thank you very much indeed for a great afternoon. And hope that many of you will be able to log on the 4th of April and see our session then. And I know that I've emailed quite a few of you to have a quick one-to-one welcome chat with me as well. But if I haven't managed to email you, that please do email me with some dates that you might be free, and we can have a quick half-hour catch-up as well. And that would be lovely. Okay, so have a great rest of the day, and thank you very much indeed. And we'll look forward to seeing you again at future events.
Thank you very much.
Okay,
Thank you very much.
Great to see you.
Bye.
Bye.
Bye. Thank you.